Hi, I'm Lauren Dang, and I'm going to talk about causal frameworks for designing studies of immune correlates of risk for vaccine-preventable diseases. I'll do this by starting with the target trial protocol and then following the roadmap for causal inference. So our agenda is that I'm going to give you some background on immune correlates of risk. I'll discuss two potential study designs, the peak antibody correlates of risk design and the test negative immune correlates design. I'll talk about target trial emulation to specify our question and the estimand that will answer that question. And then I'll give you an overview of the causal roadmap, which is an iterative process to assist with pre-specification of study design and analysis plans. I'll talk about how following the roadmap can be useful to compare peak and test negative immune correlates designs in the context of a multinational study of COVID-19 vaccination. So immune correlates of risk studies, the goal here is to estimate the association between immune markers such as antibody titers and risk of symptomatic infection. And these studies can inform vaccine development, clinical and regulatory decisions by suggesting targets for new vaccines and serving as a surrogate endpoint for many vaccines to inform decisions about new populations, new variants, and booster doses. There are two potential designs we'll consider: the peak antibody correlates of risk design, where we follow a cohort prospectively after vaccination, measure their antibodies at approximately peak, and then determine who gets COVID and who doesn't over time. Another design we can consider is the test negative immune correlates design, where we test any patients presenting with symptoms consistent with COVID-19, and then we measure their antibodies as an approximation of their antibodies at time of exposure. So these two designs have different pros and cons. They're able to answer different questions, they have different potential sources of bias, and there are differences in the feasibility, efficiency, and cost of the two designs, leading us to ask which design is best for my use case. To try to answer that question, I will discuss the pros and cons of the different designs using causal inference frameworks. Many of you may be familiar with the target trial emulation framework proposed by Hernan and Robbins, where we define components of the randomized controlled trial protocol that we aim to emulate. These components include the eligibility criteria that define the target population of interest, the treatment strategies, including any ideal interventions we would like to implement, and that includes post-baseline interventions. The follow-up period, which is time zero to the criteria that define end of follow-up, the outcome, and the causal contrasts of interest, which are what we aim to estimate, so oftentimes an average treatment effect or a causal relative risk. The goal here, according to Hernan and Robbins in their excellent book, What If, is to help clarify the causal question. But then once we've clarified the question, what comes next? Which study design best emulates the target trial? Which assumptions do those designs rely on, and which sets of assumptions are most plausible? Which estimator will be least biased and most efficient? And then how do we interpret our estimate? The roadmap for causal inference helps us to answer these additional questions as we pre-specify the rest of our study design and analysis plan. And this was originally proposed by Peterson and Vanderland in 2014. It basically summarizes decades of causal inference literature to give us this iterative step-by-step process that we can follow when pre-specifying an at least partially observational study. The steps are to define the causal question and the estimand that answers that question, and we can do that in part by developing a causal model that describes our knowledge about how the data will be generated. We then talk about the data we'll actually observe and the identifiability assumptions that will tell us whether we can estimate a causal effect or merely a statistical association from that observed data. We'll then think about the statistical estimand, that is a quantity we can actually estimate from our observed data, and the statistical model and estimator we will use to estimate that quantity. And then finally, we will conduct a sensitivity analysis to see how our results might change with the different violations of our assumptions, and compare different study design and analysis plans that we could potentially use to answer our question of interest so that we can pick the best design for a given problem. Okay, I'll talk about these two frameworks with an example of immune correlates of risk in the INVITE study. This is a large observational study conducted in 7 countries around the world, where antibodies were measured at 2 months after vaccination, And then patients were encouraged to present for testing when they had symptoms consistent with COVID to determine whether they truly had SARS-CoV-2. The primary objective was to characterize immunogenicity of these various vaccines in different settings. And a secondary objective is to evaluate immune correlates of risk in these globally diverse populations. But both the peak and test negative designs are possible in this context. So let's start following the steps of the roadmap by defining our causal question and estimand, and I'll do that using not only the target trial emulation protocol components, but also the ICH E9R1 estimand attributes, which are pretty similar. We'll start with our population or eligibility criteria, which include adults presenting for vaccination in these 7 countries. And then we'll talk about our treatment strategies. So our ideal interventions here would be to set antibody levels to a certain level at either peak or at the time of exposure, and then also to prevent loss to follow-up after baseline. Remember, these are just ideal interventions we would like to implement if possible. Our follow-up period for the peak design is the time from peak antibody levels to symptomatic COVID, or 8 months, or loss to follow-up. For the test negative design, it's less clear what the follow-up period would be because this is a case control study, so it's harder to think about what target trial we would be potentially emulating, but we might think about follow-up in an ideal trial we could emulate as exposure to symptomatic disease. Our outcome variable or endpoint is symptomatic COVID-19. And our population summary or causal contrast of interest. For the peak design, this would be the cumulative incidence if peak antibodies were set to a certain level, or it might be the relative risk comparing different antibody levels. In the test negative design, this is a case control study, so we might be interested in the change in odds of COVID-19 if exposure time antibodies were, say, increased tenfold. Now, some reasonable questions you might be asking after we have defined the target trial, our question and our estimand. Is it feasible to actually emulate this trial? Well, it's definitely not. We talked about test negative being a case control study, so it's a little unclear what design we would be emulating. But either way, we can't just set someone's antibody levels to a certain level, so we can't really emulate this trial. Nonetheless, we still might ask, well, is it possible to estimate these causal effects? That is, would it be possible to estimate what the relative risk would be if someone's antibodies were set to a certain level compared to another level? And again, we probably can't actually estimate that causal effect because of the assumptions that we're going to talk about going forward. Nonetheless, we can still ask, is it possible to estimate a statistical association with public health relevance? And I will argue that yes, we can, because it's still relevant to understand the association between antibodies and risk of disease. But even though we're not estimating a causal effect, I'm still going to follow the causal roadmap to get us the highest quality estimate possible and appropriately interpret our results so that we get a good estimate with real-world relevance. Okay, I'm going to skip ahead a bit here to step 3, where we'll talk about the identification assumptions that are necessary to conclude that we have estimated a causal effect from our observed data. Now, quickly, first we have the exchangeability assumption. This encapsulates assumptions we're familiar with as no unmeasured confounding, missing at random, and also no collider bias, which often means that we are ruling out a form of selection bias. Next, we need the positivity assumption, so we need adequate support in our data to estimate the probability of our outcome given different antibody levels and different levels of our adjustment variables. Finally, we need unbiased measurement of exposures and outcomes. So there are different concerns here for the peak design and the test negative design that I'll discuss going forward. But there are likely violations of some of these assumptions. So again, our goal here is to estimate a statistical association between antibodies and COVID, not to estimate a causal effect, but thinking through these assumptions and their plausibility can help us to decrease bias in our analysis and get a more relevant association with interpretable results. So I'm going to focus for this presentation just on this one issue, that in the peak design, we might not have unbiased measurement of outcomes if we don't have complete counting of cases. So we would need no test hesitancy. That is, people are not hesitant to test, so they show up and get tested, and that way we can truly count whoever has COVID and who doesn't. So the last step of the roadmap is to compare different study designs, and I'm going to do that specifically related to this issue of bias due to test hesitancy. Now, the test negative design has been noted in the literature to have an advantage if healthcare seeking is associated with both the exposure of interest, in this case antibodies, and selection into the study sample, in this case by testing. So in our example, some participants are reluctant to get tested because they can't afford to miss work, which they'll have to do if they test positive for COVID. So how might this lead to an association between exposure and selection? Well, in the peak design, if patients are hesitant to get tested, then the cumulative incidence will be underestimated because we're simply not counting all cases. But our relative risk estimate will also potentially be biased, and a hazard ratio estimate, although that's not a causal parameter, it is frequently estimated, that will be unbiased unless test hesitancy is also associated with antibodies. Now, what do I mean by that, and when might that be the case? Well, to evaluate that, we are going to develop a causal model using a directed acyclic graph for this peak design. Recall that we're interested in the association between antibodies and development of COVID, and we hope to observe who has COVID in this peak cohort. But because some patients might be hesitant to get tested, and we only observe COVID for those who get tested, we will only observe COVID for those who are not hesitant to get tested, and for those who are hesitant to get tested, we have to assume that they did not have the disease. Now, when might test hesitancy be associated with antibody levels? In this case, we think we have this unmeasured variable U, which is socioeconomic status, and that affects who is hesitant to get tested because those people might be concerned about missing work if they are of lower socioeconomic status, but it also may be associated with the antibody response to vaccine through the association of socioeconomic status with various medical comorbidities. This is the kind of relationship that we're worried about that will cause bias for not only our cumulative incidence estimates, but also our relative risk and our hazard ratio estimates. And as always, we need to be concerned about unmeasured confounding, which we might have if socioeconomic status affects who gets COVID, which unfortunately is probably also true. Now, how does test hesitancy impact our test negative design? In the ideal test negative design, the odds ratio is unbiased even if test hesitancy is associated with antibody levels, as long as test hesitancy is the same for those who get COVID versus other infections. And again, I'm going to explain what I mean by these potential concerns or lack of concern using a directed acyclic graph. Now we are again interested in antibodies and their association with COVID versus other infections in this case. And test hesitancy affects who gets tested and therefore who ends up in our data set. But in this context, we are assuming that whether you have COVID or another infection doesn't affect whether you get tested, as long as you have similar symptoms and you don't know whether you have COVID or not, so you're equally likely to go get that test. And in this context, even if we have this association between test hesitancy and antibody levels through the association with socioeconomic status, we won't have a biased estimate of the odds ratio. Again, we might be concerned about unmeasured confounding, but it may be likely that socioeconomic status has a lower impact on getting COVID versus another infection than it does on having COVID versus not having COVID. So while we still need to consider unmeasured confounding, this particular unmeasured common cause of our antibody levels and our outcome is less of a concern in the test negative design. I'm going to show you a simple simulation to really get at how this test hesitancy will impact bias in these two different designs. So we have this U variable here representing unmeasured things like socioeconomic status. And in the first simulation, U similarly affects time to COVID and time to other infections. Whereas in the second simulation, U only affects time to COVID, but not time to other infections at all. So that's a pretty extreme example of unmeasured confounding in this case. We have a correlation between these unmeasured factors and our antibody levels of 0.3, the same probability of testing for COVID and for other infections, and the relative risk is approximately the same as the odds ratio in this simulation, so we're comparing apples to apples, though that won't always be the case in reality. Now let's look at the results here. In the top graph, we can see that in blue, the bias in the test negative design is constant regardless of the proportion who don't test in our study. But the bias in the peak design in orange changes depending on the proportion who don't test. In the bottom graph, this is the test negative design with confounding. So the bias here in the test negative design is stable regardless of the proportion who don't test, but there is still bias because of this issue of confounding. And again, in the peak design, the bias will depend on the proportion who don't test. So the test negative estimates are stable regardless of the degree of test hesitancy, so we don't need to worry too much about how many people are reluctant to test in our study. There is now a potential for something called collider bias in the test negative design if people are more or less likely to test depending on whether they have COVID versus a different infection. But we can mitigate that bias if we measure and adjust for symptom severity and if we have a very clear case definition of the symptoms required for someone to get a test and be included in our study. There are other potential sources of bias in the test negative design, which I don't have time to go over, so I'm not saying that this design is perfect, merely that the results are much less impacted by this issue of test hesitancy than the peak design. Now, the peak design, we can see that bias does depend on the proportion who don't test in our data set. And it also depends on the association between socioeconomic status affecting test hesitancy and also affecting antibodies and who gets COVID. So to deal with this issue, we would need to try to estimate the degree of test hesitancy in our data set. We also are, as always, worried about unmeasured confounding, so we should try to measure and adjust for relevant variables. For example, we should try to measure socioeconomic status, but that's a very complicated concept and difficult to measure and adjust for in many settings. Ultimately, given that we know that we have these potential biases, we would want to conduct a sensitivity analysis, that's step 6 of the roadmap, to see how our results might change with different degrees of test hesitancy in our data set. So what have we learned about these two designs? Well, the peak correlates of risk design estimates the association between antibodies and cumulative incidence or relative risk after peak. So this is a great design for establishing a surrogate endpoint. The test negative design estimates the association between exposure time antibodies and odds of COVID-19, and this can be used as a trigger for boosting. So the two designs answer different questions. The peak correlates of risk design might be biased if we can't accurately measure outcomes due to significant test hesitancy in our study population. Whereas the test negative design might be biased if we're not accurately measuring exposures. For example, if people show up for antibody testing too late after they have symptoms, then their antibodies at that time may no longer be an accurate representation of their antibodies at the time of exposure. Though there are some things we can do in our analysis to help mitigate that bias as well. The peak correlates of design, we have to measure antibodies for a large cohort, so it's more expensive, but also more precise. And the test negative design, we only measure antibodies in those who test, so it tends to be less expensive and sometimes more feasible, but also less precise. So what does this mean in terms of which design is actually best? Well, that will depend on the degree of test hesitancy versus other sources of bias in our study populations. So one design won't always be better than another, but this framework helps us to think through the potential pros and cons of the different designs and to pick the best one that we think will work best for our given context. In the INVITE study, we are going to evaluate test hesitancy in phone follow-up, conduct both analyses, and then use our causal models to inform the interpretation of any differences in the results. The target trial emulation framework can help us with the causal question and the estimand, that is the answer to that question. And then the causal roadmap can help us to pre-specify the rest of our study design and analysis plans, help us to understand and minimize potential biases, and help us to select the most efficient and least biased estimator, and ultimately facilitate interpretation and comparison of these different designs. So thank you so much for listening. I'd like to acknowledge Dean Folman and Sally Hunsberger from my branch and the Invite team, as well as the developers of the Causal Roadmap, Maya Peterson and Mark Vanderlaan, and I'd be happy to take any questions, comments, or suggestions.